I am Dr. Derek Lee, and today I'm happy to be interviewing Peter Dumas, who's basically an orthotist out of Shriners, Montreal, and a local clinic called Action Ortho Sante in LaSalle, Quebec. Uh, Welcome, Peter.
Hello, welcome.
Okay. Now, the question I just want to be transparent to our audience as well. I met Peter about a year ago when we visited Montreal Shriners to visit Dr. Sarans for a consult. And Peter was more than happy to talk to me for, I think it was about half an hour about bracing. And we just kind of geeked out on bracing theory, ideas, and what you do. And I thought you'd be a terrific interview for our audience. Okay.
I approve.
Now, I also kind of find it interesting as well in terms of the path or progression, in terms of how practitioners or anyone channels their career path. When did you first become interested in becoming an orthotist?
So my story goes back, give or take on my 10th year now, working at the clinic. And so I stumbled on the clinic off a very different path because for me, I was helping out colleagues. My childhood friend's father owned the clinic, and he needed help around the clinic, patch it up, paint the place, or things like that. And so what happened is that they had hired me as a small little, handyman type of job. And while I was there, my jaw dropped. I saw kids with all types of issues being taken care of by bracing. And so what happened is that they noticed that I kept on asking questions and I kept on not painting and not doing what I was supposed to be doing, but I was actually being nosy about what the field was. And so when I did finish that job, that's where my past life ended.
Got it.
And so I sent myself to school because that field just kind of grabbed onto me, and I just couldn't let it go. And so that's kind of what jump started me. It was a paint plaster job that ended up becoming a career for me.
It's those influences that make a big difference.
Yes. And my biggest influence, I have to admit that there was a gentleman called Ian Finley, who was the main orthotist for especially the spine and other stuff for the Shriners for the last 32 years. And so that relationship, just kind of stuck, and we developed a very close relationship, and I followed him, stuck to his thigh almost for years. And so he retired recently about a year and a half ago. And so I'm continuing on the business that was already there. But the next generation has settled in.
Well, that's a great story, and he mentored you throughout. How did you actually meet him? Did you meet him at Shriners, or did you meet him at?
It was really at that clinic initially,
Okay.
where I was seeing kids coming in either in wheelchairs or just coming in with their families, and I was looking at all these apparatuses, braces, leg braces, and for me if we go back in time, I had no idea of this field, and so just by looking at this gentleman install these braces on these kids, it struck a chord, and I was like, what am I doing with my life when you could be doing something so positive and helping kids? And that's kind of what happened, is that once I completed that job, I just could not leave. I kept on going back, and they said, listen, if you want to come in spend a day, follow me around. And that gentleman, Ian Finley, that's kind of what he suggested. He said, come in for a day, follow me around, see if you like it before you end your your previous life into something else. And that one day just turned into 2 days to 3 days, and I just couldn't leave. And so he really took me under his wing to really transfer that 32 years worth of pediatric orthotics into my brain.
Oh, what better source, right?
Yeah. So I was very blessed and kind of, amazed on how our stars kind of aligned, and he needed someone. And I was looking for myself and trying to figure myself out in those days, and I think we just somehow our stars just aligned, and we just met each other, and he was able to retire, and I was able to kind of have a wonderful career.
Absolutely. Well, it's just beginning.
Yeah.
Well, what I was drawn to when I met you at Shriners Montreal was that it was pretty obvious that you were very keen, very passionate about it, and I guess your brain's always thinking about different theories and pathways. Um, with your experience with bracing for scoliosis, were you trained in a specific technique before? Was it more of a traditional symmetrical brace, or was it more of the asymmetric brace that you were experienced with at the beginning?
So in the beginning,
Hmm.
I had the traditional, kind of what everybody or most clinics, I would say, in North America, or if you go back a couple of years, what most people were doing. So there was the traditional Boston brace type of design, and
Hmm.
that's kind of what was the standard for many, many years since the 80s. As just that's kind of what everybody went with, and everybody kind of tagged along, and it's what was working. It had good research behind it, numbers were there, and it was a very good model to start a very, very good foundation with. And for me, a few years back, once I started to become more and more autonomous and doing my own clinics and taking over more and more, I ended up going through fittings of bracing with, uh, I had something that was not answered. Like in my brain, I just felt that the fitting was not complete, and I was always missing ingredients. So I was kind of like 80% satisfied with my fittings, and there was just something always lingering that I would go like, there's something missing. I think this could be improved.
Hmm.
And so for me, I used my training with my predecessor as my foundation, which then led me to kind of, searches and books, and I ordered books from Europe that I had sent to my office in Montreal, and I started reading on the Chanot technique, the traditional handmade asymmetric fabrication process of these braces.
Hmm.
And once I kind of self-taught myself, I needed more. And so that once I started implementing these changes into my own brace designs, I needed, colleagues, I needed people to share with, which in Montreal, I had no one to do that.
Right.
And so that led me to looking into Europe, and then finding that all over Europe, that is the golden standard. The Chanot type of asymmetric design is the golden standard.
Hmm.
And so that led me to signing up for training in Germany in order to confirm my thoughts and confirm my modification of my braces that I was kind of slowly implementing, and to see that, I'm not like, yes, I felt a little bit alone in Montreal doing it, but everywhere else, that's kind of where people are.
Right.
And so I was kind of confirmed of sharing. I was sitting with, a classroom full of people that are using this type of brace design and learning about it, how to measure for it, how to fit the braces, but also share with people that were actually there not as their first time training, but were there as a refresher course. They've already done the course a few years ago. They just needed a refresher. So they had,
Right.
a wealth of knowledge of years of already having implemented this design. And so that was really, huge in terms of, sharing. And I still have contact with some of the people I met in Germany, that we occasionally swing emails back and forth and ideas.
Hmm.
So that's kind of where I am now. So with that self-taught traditional Chanot handmade brace, with the training I participated in Germany, plus the 32 years of my predecessor, that's kind of built who I am now and where I'm kind of going with everything.
Very good. How long have you been at Shriners for now?
So the Shriners moved 5 years ago, and I was already present there about 2 years prior to the move. So I would say a good 7 years of being present there on a weekly basis.
Right. How many braces would you kind of estimate that you've made over that time?
um, the last numbers I pulled were when my colleague Ian was still coming into work, and we were curious as a clinic. So meaning both of us, since we were both doing spine.
Hmm.
So we weren't, so we didn't pull individual numbers, how much he would make or how much I would make, but we just pulled our clinic numbers. And so a few years back when he was still there, so I would say up until 3 years ago, we were both of us together doing about 500 spine braces between us both per year.
Right.
And so the last 3 years, I would say that number actually increased a little bit. So our clinic is still producing over 500 spinal braces per year.
What's the process? Is it primarily from the doctors at Shriners of Montreal, or is it from surgeons throughout Quebec, or is there?
Yeah. So in my case, because we
Mhm.
have a very intimate and close relationship with the surgeons, because once you develop this trust relationship, then the team wants to continue because there's an understanding. With working with someone for many, many years, you
Mhm.
figure out with time what this doctor likes or what this clinician or we work with nurse practitioners as well. And so by being with them all the time, you get to feed into their brain as to know what are the small details that this person likes or that person likes. And so that takes years to develop. And so once you develop those links, they don't need to ask me, or I don't often, we don't need to ask each other because we know what we want. And so that takes years. And once that kind of settles in, there's just an ongoing relationship with, they know that I'm going to produce what they want.
Mhm.
And so I have really, we work with Dr. Willette, Dr. Saran, and the spine nurse practitioner, which is Marie-Josée. And we kind of call it the spine team there,
Sure.
which are a superb team to be, associated with. And they really know what they're doing and they really know what they want. And that's good
Okay.
because it allows me to kind of really put their needs into the braces I make.
Well, on that, taking that topic a little further, when um, a patient is referred to you, is it up to you basically? Is there direction from those practitioners that this is what they want, or is it based upon their spinal X-ray what you feel is appropriate in terms of positioning of the brace, that type of thing?
Yeah. So in terms of how to fabricate the brace,
Hmm.
they really give me the go on to, you whatever it is you need to do, get it done.
Hmm.
But they will specify. So if a child needs, only nighttime bracing, so they will specify on the prescription that this child, we're prescribing a nighttime treatment. So it would be a nighttime brace.
Hmm.
If a child corresponds to the criteria of full-time bracing, then that's going to be a daytime brace. And with more significant curves or more aggressive types of setups, the team likes to use a combination of both nighttime bracing and daytime bracing to be as aggressive as possible. So that direction already comes from them when we're in clinic together. And some patients actually are in the gray zone.
Hmm.
And, are we going to only night brace or day brace or what direction? And what I do really like about the team at the Shriners is that they'll pull me into the room, into the clinic, and have a multidisciplinary discussion to go, well, listen, this is where I want to go, but these are the realities of this child.
Hmm.
And now what do we do? Do we, go ahead with A, B, or do we start with B and then we'll implement A little later? And so a lot of these decisions are actually taken together uh, in clinic at the Shriners as we're seeing patients on the go. When the criteria are very, set in stone, we don't necessarily always have to go over everything because, if the criteria is exactly for a day brace or exactly for a night brace, then the team is going to give me a prescription and they go, this child needs a night brace. And that's what I produce because it's very clear that that's what the child needs. And when it's not clear, then we work as a team and sit down and kind of crunch our heads, put our heads together and figure out what's best.
Right, more of a team approach.
Yeah.
Do you use both the Chanel style brace for daytime and nighttime bracing?
So I would say the answer is yes and no. The
Hmm.
reason why is because what I like to do is that I'll use a nighttime brace design or trim line of the brace, but the interior of the brace will be built in a derotational type of manner. So there's a way of making a nighttime brace, not as overwhelming over the chest area and not as um, covering over the pelvis and over the hip. And it's very, very, the leverage is good and there's less plastic, but the way the brace is fabricated, it's fabricated with a derotational asymmetric push from within the brace. So there's a way of making braces kind of more of a nighttime brace, but with Chanel type ingredients
Hmm.
and actually making a full Chanel brace for the daytime brace.
So with the nighttime brace, is it Chanel style, but it's just a modification, or is it something that you've kind of uh, taken bits and pieces from different bracing
It's
type?
it's more bits and pieces,
Okay.
bits and pieces, and because it's hard. Sometimes it's difficult to explain, but in bracing, there isn't one or two or three braces. It's many braces for many situations. And
Okay.
some children fit very well in certain criterias, but I'll use an ingredient of a different design and I'll implement it in this one. So it becomes like a combination sometimes of
Hmm.
a brace that visually from the outside may look like this, but in
Hmm.
reality, if you would lift up the brace and look through the inside, it's actually heavily revised in an asymmetric manner.
Hmm.
So there's actually ways to have these conversations with the team and the family on the spot, and then on the spot decide, well, listen, we're going to go with this, but it's going to include different things. So it's really not just two designs. I would say it's maybe 10, 12, 15 designs, and then I pick and assemble in my
Hmm.
brain a brace that's going to fit that person's needs.
So it's very customizable,
Yeah,
literally, right?
yeah,
Okay.
yeah. And since every single one of our braces is made to the patient,
Hmm.
there's no small, medium, large approach, which used to be the case if you go back in time with traditional Boston braces. We were able to order these prefabricated modules that would resemble the person, and then you would kind of fine tune that module, fine
Hmm.
tune it, and trim it to fit your patient. When I started, that was part of the it was a good 20 to 30% of our work was those modules,
Hmm.
and as of today, we have zero modules left. So 100% of our patients are either 3D scanned or cast molded when it's necessary for in scoliosis. Not every single child or teenager are walking. Some of them are
Yes.
wheelchair bound, or there's different realities they have to deal with, and
Hmm.
so 3D imaging isn't always possible.
Hmm.
And so I use different techniques of either physical traditional casting or 3D imaging to then move on to the fabrication.
That's where the artistic impression comes in,
Yeah.
I assume, right? Now, with if we go back to the nighttime bracing, because there seems to be a little bit of research regarding Providence brace, where it's it's getting, well, a couple articles are indicating that it seems to be almost as good as a full-time brace all the time, right? But the Providence brace, I guess, is molded with the person lying down as
Correct.
opposed. And do you do the same thing with um, the Chanel style brace for nighttime bracing, or it's also done
Yeah.
vertical?
So if there's an indication to use the brace at night,
Hmm.
we measure laying down.
Okay.
There's a with time, there's sometimes, it may sound crazy, but sometimes where the trim line of the brace would be standing, and if we would just lay the person down, they seem to be, the brace sometimes seems to be too small for them.
Hmm.
So occasionally I have up to sometimes an inch to 2 inch, and I've even had, almost, 2.5 inches of discrepancy in length of the brace from the person laying down versus
Hmm.
standing. And so when we do implement a nighttime brace, we actually measure the person laying down. And that gives us that spinal stretch, that spinal kind of some of the weights and the gravity effect on us, which compress the spine. And so the second you lay the person down, we're removing a lot of gravitational pull, a lot of that compression on the spine, and it really elongates the spine, and it also relaxes the muscles, the tissues, and the tendons. And so it allows us actually to implement greater pushes from within the brace. So we actually tend to make a nighttime brace that's more aggressive, yet tolerated, because we're removing tension
Hmm.
off the spine. So we're actually building braces that are extremely aggressive, way more aggressive than, say, a daytime brace with a person that would be able to tolerate a daytime brace. But because we're removing compression off the spine, our patients are tolerating the brace a lot more. So, and the leverage, we have access to longer leverage. And in physics, well, physics and mathematics, the more leverage you have, the greater the power. And so having a nighttime brace has proven to be extremely effective because of this additional leverage that we gain by laying the person down and really maximizing the length of the brace in its extremities.
That's pretty fascinating. Have you found yourself as a result prescribing more nighttime braces as opposed to full daytime braces?
So I do not prescribe.
Sorry,
So
are you manufacturing?
Yeah. So when the patient fits the profile for full time, and the team wants the person to be braced literally over the 20-hour mark, and they really want something 20 to 22 hours of brace time worn. Right now, we're I would say 90% of the time they're prescribing 2 braces, and the reason why is because once you trim and fit your brace for your daytime brace, and you lay the person down, you notice that sometimes you're missing 1, 2, 3 fingers of length, either in the axilla or around the pelvis. And so by having 2 braces, we're actually making one that is fit for the laying down position and accommodates that stretch. So we're actually maximizing when they're sleeping, and we're having a properly fitted brace daytime that's at a correct height for the daytime treatment. So the combination of a daytime and a nighttime brace has proven to be extremely effective. Overall, in numbers, we've already had that question asked in the past, are we doing more nighttime braces than daytime braces? I would say yes. So the team is prescribing, I would say proportionally speaking, we're doing about 2/3 more nighttime bracing than we are, simply because, if curves are, in the 20-degree range, and and all the other criteria for spine bracing, are not severe, or is a low family history, things like that. Nighttime bracing has proven to be extremely effective, especially knowing that 3/4 of our growth happens at night. So if we have an extremely aggressive brace with proper leverage at night, and we're catching 3/4 of growth, I think that combination of, maxing leverage and growth happening at night, I think that's where nighttime bracing has been kind of really showing good results.
Well, it makes complete sense. If you want to optimize verticality and being horizontal at night, then really you would think you would need 2 different braces, right?
Yeah,
and so posture. Yeah.
And that's where we are at the Shriners now. So if somebody fits the profile for over 20 hours, we're pretty much 95% of the time making 2 braces.
Is that a common trend that you're seeing at other areas, or is it kind of a Montreal Shriners process?
I have yet to speak to people that are double bracing. So I'm not sure what the setup is, say in Toronto or across Canada.
It's not.
When I was following my colleague, what he would traditionally always say that, if somebody fits the profile for full time, it would be 1 brace they would wear all around the clock. But then again, take that brace and lay the person down. Are we maximizing leverage? Then no, just because of the natural stretch of the body and the lengthening of the spine when we're laying down, then it's impossible to have 1 brace that's dynamic enough to follow.
I agree. If you just go through the logic of it, right? It's and I've never heard of the double bracing. I think it's probably because of cost as well.
Yeah, so there's insurance and things like that.
Absolutely.
And so in Quebec, we do have a system that covers nighttime bracing and daytime bracing, and that's applicable to the upper extremities to lower extremities. So there's codes that exist where a person or a child will need a set of braces to function, to walk with, and a different set of braces to, say, stretch the ligaments at night.
Right.
For the ankles or for the feet. And so there's a type of code that you would use for daytime bracing and a nighttime, but that same setup exists in the spinal section of our book. And so there's daytime spinal codes, and there's a nighttime spinal code. So that allows us to treat the patient with 2 braces with two different billing codes that allows us to fit the patient with two braces.
No, I think it's a completely excellent idea, and I'm thinking, why didn't I think of that? But I'm glad you guys did. It's very good. It makes complete sense. You get optimized correction in both postures, and generally you'll have research papers indicating that you want, and I'm beginning to find out now that it's a bit of a myth that you want at least 50% correction, because it depends on the spine, right?
Correct.
And the stiffness and the age, etc. In terms of both daytime and nighttime bracing, what kind of correction are you kind of shooting for, if you know what I mean?
Yeah. So again, these are general percentages because they, like you just said, there's numbers out there, but I've myself tried on certain patients that are either stiff, have rigid curves, or have spinal deformities, wedged vertebra or fused ribs for that matter. And so these numbers just cannot be obtained because there's other factors that are, preventing the curve to unbend itself. And so generally speaking, with, traditional AIS or early onset, when there's no other factors, no other underlying diagnosis, generally speaking, we like to reach that 50% mark with the daytime brace. So we do what are possible to reach that goal, but it's, like we said, it's not always possible.
Right.
There's even very young ones they're so small, you would say, hey, you're going to reach 50% easy. And for whatever reason, occasionally we get bitten in the butt where the child is rigid like a stone. And they're so small and it doesn't, visually make sense, but their body is just not giving into the brace at all. And they're going to develop wounds and sores way before we get any movement on the spine.
Yes.
So that's a reality. So, and then for nighttime bracing, we're very, very, very often seeing, either a complete reduction of the curve when they're wearing their brace. So we're not correcting the curve, but we're just reducing the Cobb angle. I would say anywhere from 80% to 95% of these Cobb angles in nighttime bracing we're able to really dial down these curves quite a bit. And that's, yes, there's a brace, but there's also what we spoke about, that gravitational pull and that compression of the spine. Just that in and of itself participates significantly in those results. So like I said, we're reaching over 80% to 90 and occasionally even 100, 110% of overcorrection with the hyperflexible curves with nighttime bracing, and at least 50% with daytime bracing. And with the flexible ones, even during the day, we're starting to see, over 50%, sometimes 50 to 80% with a Chanot style day brace, but that person just happened to be often very, very flexible, and there's other factors allowing the spine to be shifted in that manner. I participated in the Montreal's Spine Research Society this past year, and some of the numbers that came out of the SRS were the reason why the 50% exists is because of the pressure on each of the vertebrae. And so that pressure was calculated on the vertebral disc. And so once you have your scoliosis and you reduce the curve angle by 50%, what was calculated is that you balance out pressure across the entire vertebrae. And so you're sending signals to the body to allow it to grow on both sides of the vertebrae, versus when it's already wedged and there's more pressure on one side than on the other, then obviously it's the side that has less pressure that likes to grow faster. And that's how curves get worse. And so that 50% comes from the research that shows that there's a balancing out of pressure across the vertebrae, across the vertebral body, and it allows growth to be symmetric on both sides of the spine versus on one side. And so when we apply that theory to nighttime bracing, and we're very, very, very often getting 80, 90%, then technically we're reversing the pressure. We're putting pressure on the wedged side. So we're putting pressure on the curved side, on the exterior of the curve. And so we're not balancing growth. We're putting pressure on the outside of the curve, which means that we're allowing the internal part of the curve to actually grow more.
Mm-hmm.
And that's also a factor why nighttime bracing tends to be very effective, is
Mm-hmm.
that it doesn't just balance out pressure on the spine. It actually reverses pressure and puts pressure on the curved side, and really decompresses the interior of the curve.
And that's why you're looking, if you can, you want to get a little bit of an overcorrection
So when
in,
possible,
in
with
terms of.
both braces,
Mm-hmm.
if you gain overcorrection, you're actually offsetting growth to the other side.
Mm-hmm.
And then we could start to speak about growth modulation,
Sure.
which is a term that's used when you stop growth on one side, or limit or slow down growth in one area to promote growth in another area.
Mm-hmm.
And so if we're reversing these curves to that amount and we cross over the 50% mark, we're actually allowing for a bit of growth modulation to happen.
Now, have you guys kept track of the success rate of bracing with the double, with the nighttime and the daytime bracing over time?
So as of now, we have numbers. They haven't been crunched down yet.
Sure.
So the double bracing approach, I would say, is in terms of the medical field,
Mm-hmm.
even if I have numbers dating back about up to 5-6 years, that the double bracing tendency really
Mm-hmm.
kicked in more and more. I would say 5-6 years ago, we started to see interest in double bracing. And then since then, the proportion kind of just skyrocketed.
Mm-hmm.
So we'd have to compile the last 5 years. But again, within those 5 years, there was an increase of that proportion. So yes, are we doing it more? Yes. But we'd have to take all my numbers of how many people received double
Mm-hmm.
brace. So the numbers exist. We just need to put, either a research fellow or a med student or somebody on that, and to crunch those numbers down. So they do exist.
It would be fascinating because, again, this is the first time I've ever heard of the double bracing, and it could possibly be a game changer, especially if you're seeing the trends over the last 5 years.
Yeah,
right?
And so Dr. Saran, actually both the entire team, but this idea of crunching those numbers,
Mm-hmm.
actually initially Dr. Saran had approached me, because since we're building the braces, then we could just sift out who got a night brace, who got a day brace, and then balance out who got both braces.
Mm-hmm.
Then we got the names, and we could do a research project on that.
Yep, you just look at their X-rays and their Cobb angles over time.
And over
right?
time, and
Yep.
when the treatment was discontinued, and what's the success rate?
Absolutely.
But visually, or at least to the appreciation of the team, they've been very well satisfied and have seen an improvement overall.
Mm-hmm.
And I think that's the reason why the trend has not just, it hasn't stayed level. The trend of double bracing has been increasing.
Mm-hmm.
And it's when they do their follow-ups after that, and they realize that the curves are not only stable, but some of them are improving a little bit.
Mm-hmm.
Again, not for everybody,
Yes.
but again, it takes a bunch of other criteria. But if that tiny percentage of the curves that do improve, if they're seeing an improvement overall, then those numbers exist, and they're seeing it more and more often within their inside of their clinics.
Mm-hmm.
And so that automatically allows them to say, well, hey, I double braced this one, and this next one fits the same profile, so let's double brace this next one as well.
Well, why mess with something that's working, right?
Yeah. And
now, in terms of the brace fitting, do you try to do in-brace X-rays? Is that part of the protocol in terms of how soon after is the brace is manufactured do you do the in-brace X-rays? Is it within 2 weeks, 2 months? There doesn't seem to be any kind of standard, right?
No. So when I was in Europe,
Mm-hmm.
it was slightly over a month, 5, 6, in month and a half.
Mm-hmm.
Of brace wear before they would, in that local region where I was in, it was about I would say between 4 to 6 weeks before they would in-brace their X-rays, because they really wanted to allow time for the body and the spine to get used to the brace.
Sure.
Here at the Shriners, we're looking at sometimes 2 weeks, sometimes 3, a little sooner.
Mm-hmm.
Again, there's no golden standard as to when it should be done, but it definitely should not be done immediately after receiving the braces because that is way too soon,
Hmm.
especially for someone who's never been braced before. So they have to do a about a 2 week progressive wear uh, um,
Hmm.
at home. They have to wear the brace progressively more and more at home. So that just that in and of itself lasts about 2 weeks. And then you would add another week of them actually wearing the brace at the tightest fitting before we would x-ray the brace. So I would say here, on average, a good 3 weeks, and depending of scheduling, sometimes up to 4 weeks before they get an appointment
Hmm.
to do this in brace x-ray. So I would say anywhere between 2 to 4 weeks here, depending of
Okay.
availability of spots to check the braces, and also when they finished the progressive wear.
Okay. So if a person is doing a double bracing,
Yeah.
right, how do you figure out the timing of it? Do you do one brace first, like the daytime brace, and for 2 weeks, then you start the nighttime bracing, or you do them both right away?
So I do the fitting. So I have them come to my office to do a double brace fitting. So the
Okay.
fitting is quite long, but they come in once
Hmm.
and we fit both braces. So it's about a 2 hour appointment where we're fitting, trimming, adjusting the day brace. And while I'm in the shop cutting one brace and adjusting it, I put the patient in the other brace. So they wait and test out the night brace, and then vice versa until both braces are
Okay.
trimmed and adjusted. I do offset, then they leave with both braces, but I offset the implementation at home. So they would start one brace, implementing it slowly, and about 4 to 5 days later, they would add on the second brace.
Okay.
Not because it's too complicated to try to say, oh, here both braces and start the same day.
Hmm.
It's a very crazy schedule to try to fit both of these braces. So I give them about a 5 day offset, so they start practicing with the day brace the first 5 days,
Hmm.
and they continue on doing the progressive work with the day brace, but they start implementing the night brace about 5 days later. So they've got a 5 day, practice of feeling what it is to be in a rigid brace
Hmm.
before slapping on the night brace.
Okay. Um, with respect to the in-brace X-rays, do you want the patient out of the brace completely for 24, 48 hours, or what do you recommend usually for Montreal?
Yeah, so we'll just demystify that a little bit. So there's sometimes parents get mixed up because there's a lot of these follow-ups and in brace and out of brace, and sometimes families get a little lost.
Mhm.
So just to clear the air on that one, so when we go check a brace, when you've received the brace and you finished your progressive wear, either with a day brace, night brace, or a combination of day brace, night brace,
Mhm.
when you show up a couple weeks after receiving the brace, we do in-brace x-rays. So you do not need to remove the braces because you're going to the hospital to get the braces x-rayed. So
Mhm.
you do not remove the brace because we actually want to check what's going on when the person's wearing the brace.
Mhm.
So they go to the hospital with the day brace on them and the night brace in a bag. And we first shoot the image for the day brace, and then remove the day brace, put the person in their night brace, and then shoot the image for the night brace. And
Question.
yeah,
So the day brace is the X-rays is shot vertical, and
landing.
the night.
Night brace is shot laying down. So we
Gotcha.
want to replicate the
Absolutely.
actual conditions of the home, the way the person is wearing it.
Okay.
And so that is for the brace checks about 3 weeks, 4 weeks after receiving the brace.
Mhm.
Your 6 month follow up at the Shriners in order to evaluate curve progression or stability or see how things are going or skeletal maturity. So your 6 month follow up at the hospital, that is an out of brace appointment.
Mhm.
So whether you have one or two or a combination, one or a day or a night or a combination, both braces have to be removed 24 hours before that follow up. So that's not the brace check, that is a 6 month follow up.
Mhm.
And so we have to remove it 24 hours before in order to compare apples and apples when we're comparing out of brace with out of brace. And that's the way they can measure whether the curve is stable or not, or is it funky or is something happening.
Sure.
So it's an out of brace X-ray, and that's 6 month. That's the 6 month follow up.
Do you do? Uh, another follow-up at that particular time or around 6 months also for in brace just to recheck, or not really, not
Right
necessary?
now, no. Once we've checked the brace and we're satisfied with the initial results,
Hmm.
we just let them wear the brace as is. If the results are satisfactory for everyone, then we let them wear the braces and simply remove the braces 24 hours before the
Hmm.
next appointment. If at the initial verification of the braces, one of the braces needs adjusting, and I would say traditionally speaking, because there's so many factors to consider in daytime bracing, standing position, sitting position,
Hmm.
with the thighs flexed and not flexed, and walking, there's way more factors and biomechanics and trickiness to a day brace versus a night brace where we're simply laying down. And so I would say proportionally speaking, we're adjusting day braces more than we would be adjusting a night brace, because once you remove the gravity and compression factors, very little of the night braces actually need tweaking. Sometimes they do, but I would say most of the time they don't. But day brace being a day brace, and the compression or the kyphotic sometimes position of the person, sometimes the day braces need a little bit tweaking following the in-brace x-ray. So if we're reaching, say, 40% of curve reduction, and we evaluate that we could still gain another 10 to 15%, then we go ahead and modify either from within, or by sometimes simply pulling the straps does the job as well.
Right.
So if after a couple of weeks we're able to pull on these straps and the person doesn't complain of pain,
Hmm.
then we just give them new markers, new lines on the straps, and give them, well, this is your new position,
Sure.
and this will go reach that few percentage points that we're missing.
Hmm.
Occasionally it's a little bit more, so then we would bring the person to our office and do internal modifications of the brace, either by building up the pads or increasing the pressure, or making greater expansion rooms. So it really depends on what the result is in the in-brace x-ray. We would
Hmm.
then adjust the brace accordingly.
Very good. Now, if we touch on more of the sagittal curve, which is often quite tricky as well, or
Yeah.
even more important than the coronal. I guess there's more and more consensus with spine experts that although you might not know the actual cause of, say, idiopathic scoliosis by definition, there are other variables. But once the scoliosis begins, the process is more hypokyphosis, leading to rotation, leading to the coronal scoliotic curve, right?
Right.
Now, I guess you have to be super aware of that when you're trying to manufacture the bracing, because yes, you want to reduce the coronal curve, but how do you try to take into consideration hypokyphosis, even lordosis in the thoracic area?
Yeah. So lateral x-rays are a good way to confirm. Here at the Shriners, we always have AP and lat. And so when we're looking at the lateral x-ray, if we already see any indication of flat back, or a beginning of thoracic lordosis,
Mm-hmm.
then the brace will not be fabricated with traditional, say, Chanot derotational forces, because that would go completely against that specific person's setup. And so that would actually induce. So if we would build a traditional derotational asymmetric brace for a person with already presenting with anything close to flat back or a traditional flat back, then the problem is that you would actually be inducing, thoracic lordosis, and we'd be creating a whole series of other problems. A much more lateral type of approach would then be used. And also the exam of the person, when before we start casting or measuring, we have the person bend down, we have the person, we have to verify, palpate, and inspect the body, and then also evaluate the rotation and the rib hump. And so all these exams at that initial consult will kind of lead us to then decide what kind of brace or what type of internal modifications does the brace need to accommodate this particular curve. So I still use a Chanot design, but there will be an inexistent amount of posterior approach. It will be a very lateral type of application for these curves, because it's just it would be more problematic than anything else. And same for the lordosis for the lumbar area,
Mhm.
is that will a lot of the traditional Boston bracing have had very little lordosis implemented or built into these braces. So we'd actually almost get rid of lordosis, natural lordosis in these bracing, because they were just very stiff and rigid and
Mhm.
almost flat modules. And so by respecting lordosis, we're also allowing the body to have its natural kyphosis. And so having a brace that does follow the natural sagittal plane is key in fabricating the brace.
So if, just to clarify that, so when you're hypokyphotic and you're going towards lordosis in the thoracic spine, that's kind of the spine um, trying to unload because it can't, because it's the loss of flexion in the thoracic area. So you're trying to um, focus more on the coronal curve without touching the sagittal curve, correct? Because if
Correct.
you force it more into extension, it's just going to exacerbate everything, especially the coronal curve.
Exactly.
Mm-hmm.
So yeah, so these it's when scoliosis is very tricky and complex, and that's where in the field of bracing, there's a lot of orthotists, but spinal orthotists, there's a very few, and it takes years. And I have to say that my predecessor really, uh, really pushed that into my brain, and having somebody that allows you to learn from, and
Mm-hmm.
not somebody that's been doing it for 1 or 2 or 3 years, really someone that's been doing it for many years, allows to be aware of these things. Because as you see, sometimes newcomers come in, not always these little aspects, which are significant, but often when I'm discussing with people that do occasional spine bracing, aren't really aware of.
Mm-hmm.
And that's a problem, because if you do a full derotational type of brace on a hypokyphotic curve, you're bound for trouble, and you're actually going to make things worse. And so it takes someone that's kind of almost designated to purely spine, and that's almost doing only spine all the time, to be aware of these little differences from one person to the next, to be able to accommodate or treat the brace correctly. So I'm going back to that multidisciplinary meeting, or that consult we have with the both X-rays, to be able to decide on the spot,
Mm-hmm.
and what direction are we taking? Are we even bracing? And if we are, then how are we building this brace?
For sure,
Not
because if it's so hypokyphotic to begin with, and the rotation is driven by the hypokyphosis. So if you derotate, you're just going to make the hypokyphosis worse. That's the
worse.
rationale, right? Yeah.
That is irrational, and that's sometimes the fear
Mm-hmm.
of bracing at that point.
Yeah. It's
And
whether to do it or not, I assume.
exactly, and we've had conversations before with the team where
Mm-hmm.
the doctors were on the line, where the curve was braceable in terms of its Cobb angle,
Mm-hmm.
but was unbraceable in terms of its uh,
Sure. Yeah.
flat back. And so sometimes I know that sometimes we'll take a trial. We'll go, hey, listen, make a lateral type of approach brace.
Mm-hmm.
A couple weeks from now, we'll check the brace, and if we're not happy with the results, or it's even if you've built it very, very accommodating,
Mm-hmm.
if yet still there's a weird or uncomfortable or not satisfactory, they're going to simply remove the brace.
Right.
Because if the brace is, even if it's built laterally and the body's not cooperating, that's the other thing. It's not always the person. The body can not cooperate as well.
Yes.
And so that's where the brace checks come into.
Okay.
That's one of the reasons why they're super necessary, to be able to have numbers.
Okay. Now with the hypokyphosis, and when it gets severe as well, because there's research indicating and consensus that it's anterior vertebral overgrowth, which causes wedging at the anterior aspect of the vertebra compared to the back. And a question I have is, if if you've seen a child that seems to be the staging of it, of their thoracic spine, for instance, is it unwise to basically try to put them into a kyphotic brace because that's compressing so much of the anterior aspect as well? What do you do in those cases?
That is a very good question. Right now, I've yet to be asked to create a brace. Not that it's not make a fabric. You can
Mhm.
make anything. I have yet to be asked to create a kyphoting brace. So as of now, um, from what I've seen, I think the doctors either will brace because they see fit to brace
Mhm.
laterally,
Mhm.
or will simply not brace and keep the child under observation.
Right.
And if the curve doesn't progress and it's stable, then they
Mhm.
kind of leave things as is. But as of today, I have not been challenged in order to
Right.
fabricate kyphoting. But I think it's an interesting concept because logically, if we're able to do it from the back, then I don't see an issue with
Right. Because
doing it,
when you're compressing the vertebra at the anterior aspect, you're slowing down growth.
and you're allowing the posterior part to grow. So same thing like in traditional
Yeah.
scoliosis. And so I think it's a fair. I think it's a very interesting question actually, because we do is that for Sherman's kyphosis we build
Mhm.
braces, extension braces.
Which is
So
the opposite effect, but you're the
is the
same theory.
opposite. So I'm pretty sure that we could
Okay.
think of something, but I've yet to do that.
Okay, Peter, you can use that one. Okay. Please run with that because I
But
think just because of the mechanical nature of the hypokyphosis driving the coronal curve, I don't know if there's a way of maybe spotting kids earlier and trying that before. Anyway, it would be an interesting theory.
I think it's a fair question to even just to for
Mhm.
me in my abilities to chit chat with the team, just to implement that. Hey, we're talking. I was talking with the family, with the parent, and what do you guys think of this? And sometimes just opening that conversation will potentially allow for the hamster to start kind of rolling and going, hey, yeah, I never thought of that.
Yeah, why not try it type of thing.
Not
Well,
trying.
these are kind of the ideas I'm getting from just speaking to different experts as well, because yeah, if if the bone growth modulation works based upon the compression and decompression,
Correct.
then it's usually not applied so much to the AP axis as opposed to the lateral axis, right?
Correct.
Okay.
Yeah.
Fascinating. Yeah, okay. Now, a couple of the questions for you. Where do you see to me, you're already ahead of the curve in terms of the double bracing, because I love the idea because it makes complete sense. Where do you see bracing going or heading into the future?
Well, right now,
I know we're going to do the kyphotic bracing next.
well, that would be something instead of having traditional spine bracing or uh, kyphosis bracing. Maybe you should the lordotic brace. Yeah, you know what? I think that could be a future of bracing. So in terms of bracing, I don't think bracing is something that's going to disappear, simply because bracing allows to avoid surgery,
Hmm.
and just that in and of itself, if the teams can avoid putting hardware into somebody, they will do everything they can
Yes.
to put hardware. So bracing, it's a tutor. We're as humans, we're always going to make gardens, and we're going to have to put tutors to allow our plants and our vegetables to grow properly. So a brace is a tutor. So tutors are here to stay. um, Changes in our field are really in terms of the 3D imaging aspect. So that's where the future is that using more and more of that. So right now my setup is a shared setup because of the reality of at the Shriners, we don't just, like I said previously, we don't just see patients walking in. We see patients being rolled in
Hmm.
or pushed in. And so that is the difficult part of always using 3D imaging. So I think that, as 3D imaging improves, or applications improve, or sensitivity to imaging capture devices will improve. I think if that's applicable to other patients that are in different conditions, I think that's where we're going to gain. Plastics are plastics. Today's plastics are actually phenomenal in terms of the adjustability, the molding abilities, conserving shape, and all that. One thing that I wouldn't be surprised is if we were implementing sensors in braces in order to monitor brace wear. And I think that is something, it's been used in before for research purposes.
Right.
But then once the research is completed, that select few that have worn the sensors, well, poof, those sensors are gone, and we crunch the numbers and we produce the research. But I think having a type of brace verification would allow us to better control the actual wearing of the brace, because it's not because you give the family and the child a brace that brace is actually worn. And so I hope that there could be something that could be very easily implemented into bracing, and having an easy way to control brace wear at home. And the other challenge is not just brace wear, because you can wear a brace without pulling the straps. And so if you have the shell around you and the straps are not pulled properly, then the brace is also not doing anything at all.
Right.
So something to, I would say, to monitor, measure, the tension of the brace. There you go. That's what I was looking for.
Very good.
So not just wearing hours, but tension. And so that would prove that the person was not only wearing it, but also was wearing it at the desired position for maximum effect. Because like in anything, you have patients that have beautiful in-brace x-rays. They seem to fit the profile for good results, and they come in and the results are not good.
Right.
And then when you start to dig deeper, then you realize that, oh, well, brace wear at home is like this.
Compliance.
And the compliance is a big issue sometimes. And so I think the future is in implementing devices or little applications in order to control compliance better. I think that's where, in terms of spine, at least, I think that's where things should change. Yeah.
No, it's practical too, right? In terms of, you don't have if you're not wearing the brace and you're not wearing it properly, then what's the whole point?
That's the whole point.
All right. Okay.
Yeah.
Well, thank you, Peter, very much for taking the time to talk to me. You educated me quite a bit on bracing, especially I love the double bracing idea.
It's a pleasure. I'm just sharing what we're doing here in Montreal, and if that could kind of, have a domino effect, and if we end up crunching the numbers, because we just need to put a person on it.
Yes, you need to publish a paper.
Yeah, I'm sure that, if the numbers are great, I think it's a theory that at least, mechanically speaking, we're seeing the results. And I think there's something there to work with.
Very good. Okay. Awesome. Thank you for your time.
All right. Thank you for having me, and have a great day, and we'll speak to you soon.